Okay, well, thanks very much for the very kind invite. I'm Terry Wong. I'm a consultant hepatologist at Guy's and St Thomas's Hospital, and I'll be talking today about a project that I've been conducting in partnership with North Lambeth PCN in forming an integrated neighbourhood hepatology service. I think there may be a couple more people that we're waiting to join, so I'll just wait for one more minute before starting my presentation. So just to introduce Jay, who's also on the call. So Jay Patel is the North Lambeth PCN lead in hepatology, and is also heavily involved in terms of the Lambeth in the Lambeth PCN. So
can I just ask, thanks, Terry. Can I just ask if anyone has any questions to put them in the chat function, not in the Q&A function, or else we'll lose control. So if you put any question in the chat, and Terry and colleagues, if that's okay, at the end we will come to them.
Okay, very good. So I'll start my talk now. So just see if I can just make sure that I can just So liver disease is important. It's a major cause of mortality. This is a graph looking that, in contrast with other chronic diseases like heart disease, diabetes, cancer, ischemic heart disease, the mortality rate has gone up fourfold over the past 30 years. And not only is it increasing in incidence, but it's also now the major cause of death in patients in the working age between the ages of 35 and 50 years old. And we've seen an increase in the admissions due to liver disease as a consequence of this increasing incidence. Now, we have a high prevalence of liver disease in our locality. The reason for this is because of the deprivation index that we have in our locality, which is associated with a high degree of alcohol-related liver disease and also non-alcoholic fatty liver disease, but also because of our high population that were born both in Africa and also Southeast Asia, with a subsequent high prevalence of hepatitis B and also hepatitis C. So this is a study that we conducted in the emergency department at St Thomas's Hospital, testing all patients for hepatitis B and hepatitis C. And you can see the seroprevalence of hepatitis B and hepatitis C is approximately 1% for each, i.e. 2% of the total population, which is at least twice that of the standard population in the United Kingdom. Now, how can we prevent liver disease? Well, this is a paper that was published in The Lancet late last year, and there's a very nice review in terms of the progression of liver disease. So in patients with early liver fibrosis, they do develop liver cirrhosis, but that process can take many years. But very importantly, this process can be reversed. So this is a study on which the American Association for the Study of Liver Disease guidelines is based on. This is in patients with non-alcoholic fatty liver disease. And in this study, the patients had a liver biopsy at baseline and liver biopsy at 1 year. And in those patients that achieved 10% weight loss, which is circled, the resolution in steatohepatitis occurred in 90% of cases. And very importantly, liver fibrosis regressed in 45% of cases, stabilized in 55% of cases, and did not deteriorate. So we can reverse liver disease by appropriate intervention and prevent problems. So how are we currently managing liver disease prior to the onset of this project? Well, since I've been a medical student, the way that we've managed patients with liver disease has not changed in secondary care. That is, the GP does some blood tests, they're abnormal, they repeat the blood test, they're referred into secondary care. And once they're in the secondary care, essentially they're seen by registrars for the rest of their lives. And this has caused a very high number of patients that we're seeing in secondary care, and has caused a major backlog. And this is prior to the onset of our study. Our waiting list for the average follow-up time was around 6 months, which, I put it to you, is pretty unacceptable, really. So how can we cope with this demand? Well, we can expand secondary care indefinitely. In patients with long-term chronic liver, or we can manage these patients in the community. And we calculated that approximately 50% of patients can be safely transferred into the community. So the solution that we initially developed in June 2020, I wrote a paper with our then general manager, Aaron Horn, and that is to provide a patient-centered value-based service in the community and for early identification of liver disease and appropriate referrals, but also to have ongoing liver disease management in the community. Now, this did have a paradigm shift in our delivery of outpatient liver care. It required an integrated care pathway and a high degree of collaboration between secondary and primary care, and a very neighbourhood-based and patient-centred approach to care. And this project was designed to bridge the gap between our ivory towers and guys at St Thomas's Hospital, and also practices like the Hurley Clinic. And this is us in between. Now, we selected the patients that we felt were appropriate to be transferred into secondary care, from secondary care into primary care. And as you can see, this was the vast majority of patients that were stable. And the setting was that we would do 1 MDM per PCN per month, and we would be seeing patients or reviewing patients that were discharged from secondary care long-term follow-up, but also to provide advice for patients in terms of new patients for multidisciplinary discussions. And this provided direct face-to-face discussions in a multidisciplinary context, but also, very importantly, there was a large educational component and also cascading of protocols and best practice to high-volume GP practices. So this was the patient pathway, and that is that patients that were in secondary care, they were then transferred into the community MDT, and from there was a bi-directional interaction with the GP practices. Now, this doesn't mean that the GP practice can't directly refer into secondary care, and we would encourage that for patients with who needed urgent referrals or 2-week wait referrals. But this project is designed to create capacity in secondary care so that that can be seamless. Now, in patients in whom deteriorated in primary care, we can then transfer them directly back into secondary care, also in a seamless manner. So this is an example of a primary care protocol that we developed for patients. Now, on the background of this, there has also been an evolution in NHS policy that we've recently seen the last step of. In 2019, the NHS long-term plan recommended that we redesign services such that over the next 5 years, i.e. now, we would be able to avoid a third of face-to-face outpatient visits. And I'll see the data that we have in the end indicating that we have achieved this. In 2020, integrating care also recommended that we would provide decisions closer to communities, and also collaboration between secondary and primary care, and also between partners in a place-based setting. A further document in 2021 indicated our duty to collaborate between primary and secondary care. And also, we've now established integrated care systems, and the fuller stocktake in 2022 recommended the evolution of primary care networks into integrated neighbourhood teams. And we're all very familiar with the 10-year plan that was published just this month, indicating that we do need to move from hospital into the community, from analog to digital, and also from sickness to prevention. And I'll show you how we've achieved this with our project. All three of these shifts, 3 big shifts. So I actually originally devised this plan over a decade ago, but this initially was met with a large degree of shall I say, resistance from various areas. And initially, this took no traction because in primary care, there was the argument that this would increase their workload, and there was a fear of the increased workload and responsibility. And in secondary care, because the reimbursement was activity-based, there was a fear of the reduction in activity. Now, I must say that it's unlikely to reduce the activity. What the effect of this would do is reduce waiting lists, because as we can see, that the demand is probably limitless. So after I wrote the document with Aaron Horner, we then formed a community hepatology working partnership between secondary care, but also it was very much a primary care based with Adrian McLaughlin and George Verghese. And subsequent to this, we progressed. I've been in very close contact with Toby all the way along. We were allocated a transformation manager and project manager. With a very heavy and welcome support from George Verghese and Toby. We met with Ruth Bishop and Beth Carthy with the charity, and we were granted funding from the charity for the pilot. We signed a memorandum of understanding with the Lambeth GP Federation in April 2023. We started this, and at around this time last year, we were up and running. And that is that we finalised our standard operating procedures at the end of 2023. We had a full staffing complement. We meet on a weekly basis in the Pavilion Medical Centre, and we commenced this and have been up and running now for a year and a half. This is the grants that we were granted with a very kind funding from Guy's and St Thomas's charity. And this is our meeting centre. This is the Pavilion Medical Centre in Brixton. This is myself, my consultant hepatology colleague, Matt Long, Sam, who was our project manager, and mine was admin, and you can see Jay here. So, but not only do we have Guy's and St Thomas's consultants, but we also have the privilege of having the Professor of Hepatology from the Institute of Liver Studies at King's visit us and see our services. So this is Phil Newsom, who very kindly visited us from King's, from the Ivory Towers. So we're bringing best practice from the best liver units in the world into primary care. So we have 4 project streams. The first stream was to transfer follow-up patients from secondary into primary care. The second stream was to investigate new patient referrals. The third stream was to detect in the community patients with significant fibrosis or cirrhosis. And the fourth stream was to establish the use of the community fibroscanner. I'll show you the utility of all of these streams in a few minutes. Now, the community fibroscan is a great resource. This is based on the Acumen Health Centre, and this is our linchpin to our whole service. It's Jonathan Presky, who's our liver CNS, worked with me for many years at St Thomas Hospital, and is now delivering the fibroscan in the community, but also other factors such as face-to-face contact and also brief interventions. So this is our standard operating procedure that we finalised at the end of 2023. So in terms of our first stream, which is the transfer of patients from secondary into primary care, we identified about 15,000 patients who are under gastroenterology follow-up. And in Guy's and St Thomas's, liver disease falls under gastro, but is in a separate clinic. So of these, there were 3,500 that are under hepatology follow-up. On all of these, 251 were located in North Lambeth PCN. Now, we went through the notes of these 250 patients and determined that 175 patients were amenable to be transferred into primary care. So that's over 50%. We then managed to contact 126 of these patients, and the ethical committee mandated that we had to ask these patients to opt into the project. So of these, 90 patients opted into the project, and these are now under active follow-up in primary care for the liver disease. And as you can see, the NHS document from 2019 recommended that we transfer 1/3 of patients from secondary care to primary care. And as you can see, we have overachieved this objective. We've transferred, of 251 patients, we've transferred 90 into primary care. Now, the second part of this was the case finding project, and this was again funded separately from NHS England. And this looked at patients in terms of the identification of patients in the community at the risk of liver cirrhosis. Now, this is our usual protocol, and the reason to put this up is that I'll show you how we've managed to avoid the referral to the hepatology clinic, which is the bottom line here. And that is that in patients with liver fibrosis, we do the FIB4 score. And if the FIB4 score is more than 1.3, we would refer into the hepatology clinic. So in this study, this project, we identified using an EMIS enterprise search, and Zafar, who's one of our data analysts, was very helpful with this, to identify 9,000 patients who had identified at high risk of having liver cirrhosis. That is those patients with age more than 50 and non-insulin dependent diabetes, Black and ethnic minority with non-insulin dependent diabetes, and a body mass index of more than 27. A non-Black and ethnic minority with a non-insulin diabetes and a body mass index of more than 30, an ethanol intake of more than 100 units per week. And now we identified 9,000 patients out of a total population of 90,000 in the North Lambeth PCN. But we did not have the facility or funding to perform FIB4 scores in all this 9,000. And because of this, we selected 3,000 patients out of the original cohort of 9,000. And all of these patients were invited to have a FIB4 score using AccuRisk. We established a one-click FIB4 request in primary care. And initially, we established a reflex ELF score in those patients with a FIB4 score more than 1.3. But we did find that the ELF score was not very effective, and we switched this to FibroScan. And we would feed these patients on the new patient pathway. But as you can see here, this was a totally digitally based paper-free system, and we've moved totally from analog to digital in using this. So initially, we started off with 90,000 patients who were registered in the North Lambeth PCN. Of these, 9,000 were identified at the risk of having liver fibrosis using the EMIS search. We selected 3,000 patients, and all of these patients were invited to a FIB4 score with AccuRisk. And of these, about 10% attended for the FIB4 score. And this is one area that was actually worried me, and that is that over 50% of those patients who have FIB4 scores had a FIB4 score that was indicated that they would have either advanced fibrosis or cirrhosis. Now, under the normal liver protocols, these patients would then all go on to be referred into secondary care. So this would generate a further 153 secondary care referrals. But because we had the access to a community fibroscanner, we offered all these patients fibroscans. Now, of the 153, 49 attended for a fibroscan. And of these, only 3 had fibroscans indicated that they had advanced fibrosis. All these patients had liver disease etiology screens. Of these, 1 had autoimmune hepatitis, very clear evidence of autoimmune hepatitis, and has been referred in. But the remainder had negative liver disease screens, had non-alcoholic fatty liver disease, and we're following these up in the community. So there are a few take-home messages from this study. The first take-home message is that with the community, the neighbourhood team, we can avoid 90% of referrals. But this is a collaboration between myself, primary care, and also the ability to be able to do the fibroscans in the community. So our current work plan is to really look at those patients who didn't opt in. Now, there is a debate as to whether we actually need to have patients opting in now because of the results of this pilot. We have an open door policy on Thursday afternoons for the MDT, and that if any general practitioner has got any liver referral on a routine basis, we're very happy to discuss this with them. And we've now established the community fibroscanner, which is now currently actually underutilized. We have a large amount of capacity there, and we can perform more than 2,000 fibroscans per year. So the current state is that we can do an MDT in the Pavilion Medical Centre, and we can discuss, and we've discussed this with Jay, we could probably review more than probably up to 20 patients. I think we could be agreed on this in our weekly MDT. And we can also have direct referrals into our MDT, but also into the community fibroscanner. So our vision is to roll this out amongst Lambeth. We originally developed this on the background of a PCN, but of course we're switching now from PCN into INTs. There will be 5 neighbourhoods in Lambeth, Jay knows more about the detail regarding this, and 80,000 per neighbourhood. And there'll be one MTT per month per neighbourhood. And we think that this, numbers-wise, this would be absolutely perfect. Now, in terms of staffing this, we've got the numbers here in terms of the staffing, and we're probably looking at total clinician costs and the full-time CNS costs, and it's all been costed here. But if we were to look at this would certainly be a cost saving when compared with these patients going to secondary care, over and above using up secondary care resources when you're looking at a PBR basis. Now, the other advantages of this project is that it certainly aligns with the 10-year plan for integrated neighbourhood team-based care. This is definitely upskill primary care, and Jay is definitely skilled easily as much as any registrar who sees patients in my clinic. And the establishment of the primary care-based FibroScan as a triage tool will avoid 90% of patients with secondary care referrals. So in terms of the 3 big shifts, we've certainly managed to shift patients from hospital to community. We've definitely shifted from treatment to prevention. And also, we've demonstrated that we do a totally paper-free and have shifted from analog to digital. Right, well, thanks very much for your attention. And if there are any further questions, be happy to take them now, just to kind of take off sharing. So,
Terry, thanks so much. Really interesting. This is an exemplar of how we should be leaning into communities as we move to this new world of neighbourhood working. So, Terry and team, fantastic. Jay, I don't know if you want to add anything to what Terry's.
No, not just to repeat the same old thing, but actually, I think we started a lot of this before the 10-year plan came, because the direction of travel is pretty obvious. And I think we've demonstrated quite well how both primary care and secondary care can work well together to help each other's needs. And I think certainly this model is very scalable. And it's also a learning opportunity for people in general practice. It does confer greater workload in primary care, but I think that if there's a way that we can unlock various resources, and resources doesn't always have to be money, it can be people and time, we can actually do things which work well for patients and work well for each of the individual organisations as well, because the last thing I want is to be referring someone into the liver unit and being told we've got an 8-month, 9-month waiting list, and I think we have to do things in a different way.
Thanks, Jay. So I've got a couple of questions. We'll come to the $1 million question, which someone's put in, which is how do we get involved? But just for now, if I can ask 3, if that's all right, just I'll remember them all. And the first one, just a question around the sensitivity and specificity of the FIB4. For the obvious question from the numbers you showed, maybe you can start with that, Terry.
That's such a great question, Toby. That's the reason I've got Phil Newsom coming down to end. I specifically asked him this. Now, the sensitivity of FIB4 is pretty high. Sensitivity of FIB4 in the previous studies is around 90%. But the thing that really surprised me was the specificity. Because if you look at the previous studies, the specificity is between 30 and 60%. But the specificity in our study was very poor. It's only around 10%. And I asked Phil this directly because he's been involved, Phil Newsom, who's Professor of Hepatology at the Institute of Liver Studies, and very clearly, and the reason for this is that the specificity has been designed in secondary care populations, not in primary care. And so we've opened this out, and this just goes to show that, when we go into primary care, those patients that they studied in the specificity have all been highly selected. They've been highly selected. So we're now going out to the community. And this just goes to show, that we have to have a community FibroScanner in order to sift out the patients. But that's a great question, Toby. Great question. And this is another reason that we need to do this in the community.
Thanks, Terry. I've got a couple more. So you mentioned that 90% of referrals can be avoided. Is that on the assumption that you were screening patients based on the criteria which you mentioned? So what does that mean for everybody else with deranged LFTs in some way? I mean, is it possible to, I don't know how clear the pathways are, but is it possible to sort of clarify pathways which might screen out the right patients for groups not captured by that cohort?
Yeah, so the cohort that we're looking at are routine patients that are most likely to have non-alcoholic fatty liver disease. This excludes patients who are jaundiced, acute hepatitis, 2-week waits. Those obviously needs going directly in. But the aim of this is to create the capacity so as we can get these patients in quickly. Yeah. So now, in terms of other screening, absolutely. I mean, what I'm doing in the community is exactly what I'm doing in secondary care when I'm talking to registrars. So there's no difference in the care that we're delivering. So I hope that's answered your question. So.
Thanks, Terry. So the other question I had, which is very similar to the question which Sylvia has put in the chat here, is because my numbers, I can't remember what that numbers were, but it seemed like a minority of your patients were from North Lambeth, and by extension, probably a significant minority from Lambeth, maybe Lambeth and Southwark. So how do you scale this? And to Sylvia's question, how do others get involved?
I think I'll pass this over to Jay, because he's one of the directors of the Lambeth Healthcare Limited.
So I think the natural scale up would be that the direction of travel is Lambeth will be split into 5 neighbourhoods, and the neighbourhoods are roughly about 100,000. It's a large neighbourhood, but that's what a neighbourhood is. And we can see from this PCN that the population size is 100,000. So actually, we know it works. It's just now getting the people to actually come and do it. So we know a core group of people who would do it. My suggestion would be you'd start neighbourhood by neighbourhood, so you go sequentially. You wouldn't do all at once. You do one more neighbourhood, then you do another, then you do another, then you move to all 5, and essentially you'd be having 1 MDT per neighbourhood per month, and that core team would comprise of 1 consultant hepatologist, 1 GP, and 1 administrator who supports the sort of work, the administrative work around it.
Well, we've got a hand up. So let's go to Sylvia. You asked the question first.
Yes. So we have worked with Rob McCarthy on the CKD pilot. So we kind of it was very, very similar. Sorry, can you hear me? It was very, very similar to what you said, and we are just finishing this one. So that's why I asked, how can we get it, as we are already in trajectory of doing this. We've got all the staff involved, all the clinical leads, admin, clinicians doing clinic. So that's why I asked, how can we get involved before that one finishes, and if we can start this. We do have MDTs as well, so we are very, very used to doing this already.
So sorry, Sylvia, which group are you in? Lambeth or in Southwark?
I'm sorry, I'm in Bromley. Oh,
Bromley. Okay, right. It's really great you're working with Rob, because Rob was one of my very early supporters in 2010. He's really into this, and I'm really delighted that he's managed to get it going in some other group. So the process is actually, because Bromley, your local secondary care would, I presume, be would it be Lewisham, Greenwich, Prue? Okay.
Kings.
Again, this would require buy-in from the Prue. There's of course a lot of background work that I haven't talked into, in terms of the patients that would have to be identified within the Prue. And then there would have to be a clinician going through on those on an individual basis to select those patients to be transferred. Mm-hmm. And then they will have to be transferred out safely into the MDT. Mm-hmm. But it's certainly something that's, we've got the pilot, and we have the framework here and the process involved. And once it's actually physically done, it works very well.
Thank you.
Yeah. But I'll be very happy to speak to, be delighted to speak to Rob about it.
Thank you. That would be very helpful.
So is Rob working with Bromley PCN now, is it?
No. So Rob, I think he's moved, hasn't he? So he was, I think he was at ICB, and he's moved. Yeah, but if you do email him, he'll be able to let you know who replaced him.
Yeah.
I guess.
So.
Thank you.
We obviously do also have an SOP. It's an SOP that's being iterative and generated as we go along, but it's pretty it's had multiple versions, so it's a sound document, and of course we would share that with partners across South East London.
Thanks very much.
you.
So there's a question here about funding, and Terry and I have spoken on this before. So could you elaborate on how the funding model will work? And I suppose the question is how do you resource it when the grant funding runs out? I mean, in this world of little extra money being out there, it's either a question of moving human resources into community or achieving some sort of cost out in the acute settings. What's your view of that?
Well, I mean, unfortunately, Toby, I mean, I would probably bounce this back to the ICB really, because there has to be some sort of a collaborative commissioning approach to this. You know, from because in terms of the health economy and total healthcare spends, this is definitely cost effective. But you know, this where it's funded, you know, this is probably beyond my pay grade, I'm afraid. You know, we've been very lucky in terms of getting charity funding to get this off the ground. In terms of if we were to cost this up on a PBR basis, it's definitely cost effective. And one could argue that if it's costed up on a PBR basis, perhaps that funding should come directly from the ICB. But you know,
yeah, but we could maybe think. Oh, I think the argument is that there is, with no extra money, investment somewhere has to be achieved by savings elsewhere. Yeah. And I suppose the question might be, and maybe you can answer it now, is that deliverable, do you think, within the overall envelope? I don't mean for you specifically, but just generally, if you look at hepatology services in the UK, do you think there's over time there could be sort of redistribution of resource from hospital to community, which is certainly what the NHSE and long-term plan expects? Yeah, I mean it's difficult. I don't really, and it's just difficult to know how a commissioning framework that would incentivize work like this, but I'm afraid it has to be found. Yeah.
Is this symptomatic of where we are? Because the 10-year plan was great on ideas, but it didn't actually deliver the mechanism of how any of this is going to happen. And we might have this period of inertia because we know what we need to do, but no one quite knows what to do or how to do it. And also people are worried about their own departments and risk because everyone's scrapping for money and resource. I think we're in a place where we've got something that's up and ready, but we just don't know how to deliver it. And I don't know whether there's going to be any. I doubt, having been at the King's Fund recently, government have any clue about how they're going to have any levers made available to ICBs and clinicians. I just don't know, actually, and this is where I guess I would want to speak to ICB colleagues, see what their thoughts are, and all of us sit in a room and just work out how we're going to do some of this, because it's not going to be. This is not the only project where this ask is going to be made of.
Yeah, I suppose one of the questions there, what does it look like in the world of strategic commissioning? So it'd be helpful to have more discussion about what outcomes should look like here and how you think about commissioning for those outcomes, because this is very much the direction of travel. But some difficult questions there. Hopefully we'll sort of start to work through. And if there's any other question, I can't see other questions in the chat, but do put your hand up if there's anybody else there. I suppose the other question, which I think we did talk about before as well, is as we do move into neighbourhood working and more of these ideas are sort of piloted, proof of concept achieved, and want to scale up. And from your perspective in primary care, do you see how they can all work together? So we've got a cardiometabolic MDT and a hepatology MDT and diabetes and whatever else it may be. Do you see how they can kind of coexist before the drain resources becomes challenging?
Yeah, I think this is a common question that's asked because everybody's in their silos. So everyone, the cardiovascular specialist, the hepatologist, the renal, the rheumatology, I'm sure everyone has got this idea of how we sort of move to community. And the problem's going to become, before you know it, you're going to have 100 MDTs and it's just not going to be workable. So there's got to be a bit of work around what are our priorities and how do we actually, some of it just may be who got there first. So it may be hepatology is going to be a goer in our area because we're there. But we're going to have to look at that because there just isn't the people, even if you have the money at the end of the day, there isn't the people to man all these MDTs. So that's one of the questions. I thought you were going to ask something else around where does the governance sit? And that's going to be another big question that I'm wrestling in my head as to how we do that, particularly when things go wrong. Where does the governance and clinical responsibility lie here? And that's another big piece of work that we have to get through.
Brilliant, thank you. Do we have any other questions? I don't think we do. Okay, well, that was really, really helpful. I mean, it really, as I say, a really great example of how we should all think about working differently in this new world. And we're very grateful to your teams for leading the charge on that, because we should all be looking to, as I said at the beginning, exemplars of really good practice. So presumably there'll be more data coming in over time. So it'd be great to maybe come back in the future and revisit this and understand how you sort of stabilise it and hopefully roll it out into other neighbourhoods and PCNs, which I think is your intention, isn't it?
Yeah.
At this stage, so at this stage, I think that we're not, until we've got secured funding or resourcing, we're not going to move to more than one PCN or one neighbourhood. We're going to stick to ours. I think there's no, it'll be frivolous to actually move and expand it when we don't have a clear envelope going forward. So what Terry and I do is trying to make sure we extend what we've got right now, make it as good as we can possibly do it. And then, as commissioning discussions progress, to look to then go on as a sequential to further neighbourhoods.
I suppose just one more question is just around the mechanisms here. So it sounds like you have the gold standard, which a gold standard will always be getting people together in a room and talking about something. But in this day and age, sometimes we have to compromise that just to optimise the resources we have. So are there other ways of delivering this? So, for instance, there are models where people are putting requests for secondary care directly into EMIS, and secondary care will dip into EMIS. Are there other ways that you might achieve the same outcomes, do you think, or do you think there needs to be the MDT?
No, that's an excellent question. We're progressing on that sequentially as well. So the first thing, for example, we were meeting face to face, and that's always sometimes been a barrier. We're now meeting virtually. So today we're going to have a virtual meeting, and it may be there's expansions to that. So lots of different things that make it easier, that you don't necessarily need to have people in the room, but you need people connected. So yeah, that is the direction of travel. As you say, gold standard, but we've got to be realistic. Resources as well.
Brilliant. So there's another. I'm just trying to read this comment you put in the chat, Patrick.
It's a lengthy one. It's just to say that I'm sure that the trust would be involved, but from the charity's perspective, in that we fund a lot of projects and pilots, it's how it is that those can be seen beyond the 12 or 24 months and the great work that Terry and everyone has done. So I think it's in everyone's interest if there's a way that strategic conversation could be happening, and any support from our perspective as a funder and a partner. So
yeah.
Great. Brilliant. Thanks very much, Patrick.
Well, listen, thank you so much. That was really, really, really helpful, and hopefully the first of many sessions around neighbourhood working. We look forward to bringing this back. I think it's really important that we do. So thank you for the offer. There's no other comments from anyone. Just pausing. Okay, doesn't look like it. Thanks ever so much. Good to see you all. We're pretty much on time. Thanks very much, Jayesh and Terry, for presenting. Thanks ever so much for all of you.
Great. Well, thanks very much for inviting us.